So thank you both very, very much. We've got the panel set up here. We're going to have some questions that are going to come your way. I wonder if Dr. Johannes Mayr, is he here with us today? Dr. Mayr, how are you? Johannes is from Switzerland, professor of surgery in Basel, Switzerland. Do we have his 2 slides? He wants to show 2 slides about fracture stabilization that he uses over there. Good evening. Good evening there, Johannes.
Yeah.
Johannes, give us a minute so we can unmute your phone here.
Yes.
Okay, I hear you.
Can you hear the voice?
Yes.
I can hear you.
Yes.
Okay, it's fine.
Do we have his slides up there? I'm working on it. Just give us a second. You gentlemen did a fantastic job. We're right on time.
Yeah.
How about Dr. Petty? Is he coming up? Dr. Petty ought to be on the screen also.
I'm here.
Okay, good, John. How are you?
Hello, John.
Good. I'm doing great.
I'm working on the slides.
All right, well, let's, while we're waiting on the slides, there are a couple of questions here that came in from the audience, and I wondered if maybe you'd react to it for the whole group. One of the questions was, do you do compartment measurements for patients with the
meningococcal sepsis?
The meningococcal sepsis. Dr. Schmitz, you want to comment on that?
Yeah, I think that commonly what you'll see is that's a more distal injury, and so you'll see that they tend to have thrombosis distally. So in my experience, I haven't had to really look at compartments in the lower extremity because they tend to slough off their toes. But if there's a concern, then I would caution you to go ahead and you can check the compartment pressures, but in my experience, it's more of a clinical diagnosis. And I think that sometimes it can get you into trouble with trying to check pressures, because it was mentioned earlier in one of the talks from the previous session that if you get a number that you like, you release the pressure, and if you get a number that you don't like, or you release the compartment, if you get a number that you don't like, you don't trust the number that you got. So I teach all my residents how to check the pressures, but I really believe it's a clinical diagnosis, and if you're concerned, you err on the side of caution and release those compartments.
Dr. Henkin, what are your feelings about it?
Yeah, I think that Dr. Schmitz hit the nail on the head there. It's usually a sort of distal small vessel injury that you start to get necrosis and vascular problems distally. As you take them back or as you go to the operating room, if you think that there is an issue with the compartments in the more proximal aspect of the limbs, then you certainly check it. But oftentimes not as much of an issue in that diagnosis versus a traumatic type of injury.
Dr. Boyer, do you have any opinion about that?
No, I think that the points have been made well, that if you suspect compartment syndrome, you're thinking about measuring compartments, you probably ought to be releasing them.
Well, let's what do we have here? Let me see. We have another question from the audience.
Let's see.
The question I have for all of you is that one of the biggest challenges is the fact that you have a child that comes in with a fracture dislocation and a vascular injury, and you have a tib-fib fracture distally, you have a vascular injury. What is the sequence? Should you be first doing the fasciotomy before you move to anything else by doing hemostasis and then the fasciotomy, or do you do hemostasis, put the shunt in, or try to make the connection between the vessels? My experience has been that everybody focuses on the vessel and forgets about the leg. So I just wondered if each of you would just give us your opinion about how this should be approached. Dr. Schmidt, you're go ahead.
Well, I think the first thing is if you have a true laceration, then you need to get that extremity out to length. And you can do a quick reduction on these patients and then let your vascular surgery colleague at my hospital's vascular surgery colleague perform the shunt and repair. What I've seen a lot of is they have vasospasm, and so I think you need to first prove that they have a true arterial injury. And so I think it's quick and easy to do a quick reduction on these patients, at least get them out to length. I'm not saying doing any external fixation, but if you get them out to length, document that they have a vascular injury, you can then do this shunt, and the X-Fix can be applied either in coordination with the shunt or, slightly thereafter. But first thing is making that true diagnosis because in blunt injuries, a true vascular injury is pretty rare in these patients.
Well, let's just assume there's a vascular injury. Dr. Elster, what would you do?
Yeah, I think the critical thing here is time. Can you hear me?
Yes, we can. Clear.
I think the critical thing here is time, and I know we're all taught you have 4 to 6 hours, but there's some very nice studies that have come out of work from one of our military vascular surgeons, Todd Rasmussen, that shows that every hour counts. And as you extend that ischemic time beyond 2, 3, 4 hours, you pay a functional deficit in the future. So you need to reestablish. You need to obviously get hemostasis. You need to reestablish blood flow in a timely fashion. So if you're dealing with a situation that's you're only an hour or so into it, sure, you have time to go ahead and take care of the fracture. However, if you're getting out to 2, 3, and more hours than that, then you have to reestablish blood flow with a shunt is an ideal way to do it until you go ahead and get your fracture reduced and your vascular repair done.
Yeah, but see, I think you're missing my point. My point is, I'm not worried about the fracture. I'm worried about the compartment syndrome on a patient who's had an ischemic leg because of a vascular injury, and you are going to take, how much time are you going to take before you do the fasciotomy? Do you do it immediately, or are you willing to sit there and let them put the vessel together and then do the decompression?
It's a timing issue. If it's early on, you can do the fasciotomy at the very end. If you're out several hours, put your shunt in, do your fasciotomy, and then come back and do your vascular repair definitively.
Dr. Cannon, what do you think? You're the vascular surgeon.
So, truth in advertising, I'm a trauma surgeon,
All right.
but I do have an interest in pediatric vascular trauma. I think from a very practical standpoint, the sequence of events that works best for me, if you have a combined orthopedic and vascular injury, is to insert your shunt, do your fasciotomy, then have the orthopedic team stabilize, typically with an external fixator, and then reassess the patient. If they're in shock, then they need to go back to the ICU. They can go to the ICU with the shunt in place, and then you bring them back later for your reconstruction. So the sequence of events that I really prefer is shunt first to get as much blood flow distally as you can, followed by fasciotomy, then bony stabilization, then reassess and reconstruction at a later time.
Could I insert a word, Dr. Eichelberger? I would like to make the case that doing the fasciotomy at the earliest possible time is the smartest way to go because it lowers the tissue pressure, which in essence improves the perfusion pressure across that tissue. So if you can drop the tissue pressure even down from 20 to 2, you've increased the perfusion pressure by 18. And that buys time for you along the way. And I think it's the safest, smartest thing to do to buy that time.
Dr. Boyer, what do you think here?
I think the last words were very right on. I believe that you need to get vascular control first, stop the bleeding, prompt fasciotomy, revascularization, whether it be with shunt or formal repair, and then take care of the bone.
Gentlemen, I think I don't want to tell you who I agree with, but I tend to lean towards Dr. Boyer and my good buddy here, Dr. Meredith. So in my experience, the biggest error in judgment has been to wait too long to do the compartment decompression. It's just a big mistake. And we always try to figure out, how much time here and there, and we're just always wrong. And we end up with a kid who just can't walk anymore. I want to give Dr. We have a question here from Dr. Maddox. Do you have?
Yeah, Dr. Maddox wants to know what is the role of near-infrared spectroscopy in evaluating compartment syndrome?
Any of you gentlemen that have experience with that?
Experimental, not proven, deserves further study.
Okay, I like that summary. Perfect. All right, I'd like to have Dr. Mayr give us a quick, he's got 2 slides. He wants to talk about his stabilization of distal fracture. Can we have his slide come up? Go ahead, Johannes.
Yeah. Dear faculty, closed reduction and intramedullary stabilization of displaced diaphyseal long bone fractures of the lower extremity, as recommended by Prevo and Firica, is widely accepted in children nowadays. However, the stabilization of spheroid and long oblique and multifragmented fractures may result in insufficient biomechanical stability in the lower weight-bearing extremity, especially in adolescents and obese children. This 9-year-old boy sustained a displaced fracture of the femur in a trampoline injury. Closed reduction and intramedullary stabilization using interlocking titanium nails was carried out. The proximal nail end was impacted into the dense spongiosa of the proximal femur. Correct alignment and completed consolidation was noted 6 months after the injury. Here you see displaced fractures of both tibia and fibula in a 9-year-old boy. Stabilization by insertion of interlocking intramedullary nails was carried out. Correct alignment and begin of consolidation 1 month after the injury is visible. Thank you for your attention.
Well, thank you very much, Johannes. Johannes is a pediatric surgeon. He's really a trauma surgeon. He does orthopedics and everything else. So he sets a high bar for all of us. Would anybody make a comment there, Dr. Schmitz? You mentioned this during your talk. Do you agree with this?
Yeah, I personally haven't used the kind of pseudo-locking option for these flex nails. I've seen it reported before. I think in the tibia it's a great idea. I think that in the femur you have multiple options, but I'd like to see this studied long term because I think it does potentially give you an option for some of the what we call length unstable fractures. And that's been a problem with the length unstable fractures is trying to treat them with these flexible nails. But this locking option seems like it might be very viable.
Good. I would like to have Dr. Petty. He's going to present a case to you, gentlemen, and we'll start going through the case here. And John, if I give you the signal, just hold a second so we can get some discussion going on that. Okay?
That sounds good.
Do we have his slides up?
Well,
and I haven't had the webcam invite if anyone's pushing that button, but
we can hear you clear.
Okay, well, I'll just kind of keep talking. So thanks to all of our esteemed panelists. This is an interesting case that we had a few months ago. It's a 2-year-old boy who was in a car seat and restrained, but was involved with a head-on motor vehicle crash and was noted at the scene to have an amputation of his right upper extremity at the level of his shoulder. He was extricated and brought by helicopter here to the trauma bay. And in terms of things that would sort of globally indicate the status of the patient, he was in reasonable shape, but certainly had some hemorrhagic shock. But pulse, blood pressure, his temperature was low. The folks in the field, I think, did an admirable job of managing both the patient and the extremity. They had put sort of a pressure dressing, you'll see in the photo in a second. Tourniquet would be a tall order for a patient like this, and then had preserved the arm in a cooler. Put him in spine immobilization and brought him to the trauma bay. Marty had asked me to just sort of comment on some, in the spirit of first responders or bystanders, what do you do in the presence of an amputated extremity? And I think just sort of the 3 C's there: clean it if you have saline or some physiologic solution to wash off the gross contamination. Cooling, the target should be about 4 degrees, not freezing temperature, but slightly above. So if you have access to refrigeration, that's probably the best. But barring that, putting the extremity, fingers illustrated here, in some moistened gauze in a plastic bag, and then putting that on ice, but not allowing the skin of the amputated part to be in direct contact with the ice. And then thinking about the clock, it's already been mentioned that time is of the essence if you're going to be in the business of replanting amputated parts. So 6 to 8 hours would be a goal, but sooner is always better.
John, you could turn your webcam on now.
Oh, okay. see.
Top right corner of that big box where all the webcams are.
Yep. Sorry.
It's all right. If you don't see it, you can keep going.
Yeah, I think I'll keep talking and I'll fiddle with the video. I had my Botox injections, just for this thing, but you'll have to know that. Anyway, these were photos that a well-tuned-in resident took, actually, from the trauma bay of this patient. And I don't know, Marty and Wayne, if this might be a good time to pause and pull the collective wisdom of our panel.
Well, I would show the X-ray. Show your next slide.
Okay. So here's the X-ray. I think one of the principles of possible replantation or limb salvage would be to assess the state of the amputated part. And so we have an X-ray both of the child and of the amputated arm.
Okay. Dr. Enken, you saw that in the emergency room. What's going through your mind right now?
Well, the X-ray of the amputated part looks pretty good, so I'm happy with that. No other fractures. I think it becomes it's important because you get to understand the amount of soft tissue injury based on the bony injury of the amputated part. And sometimes you get an X-ray of the amputated part and it's so mangled that you have to sort of temper your enthusiasm to try to salvage it because there's so much soft tissue injury. But that amputated part looks pretty good, the rest of the arm, and it did so in the picture as well.
Dr. Elster?
Sorry, go ahead.
No, go ahead. Go ahead, Dr. Enken. What were you going to say?
So I'm not a vascular surgeon or a microvascular surgeon, but I would caution two things. One is that, young kids, like I said, have the tremendous ability to heal and to rehabilitate. And so I would, make a push, and I can't say in this particular instance right this second, but I would make a push to not snap to judgment and say, well, there's no way we can re-anastomose that. The other issue that strikes me is that it's going to be very difficult given the location of the amputation and the very small proximal segment to fix to in the shoulder, in the proximal humerus. In this small child, that's a Herculean task to try to get the bone to sort of temporarily, but certainly not impossible. So, I think that you have to think always about trying to save things first.
Dr. Cannon, what do you think about the vascular situation here? How would you approach that?
So as our microvascular surgeons described in our center, they really start with working on the amputated digit or limb to really assess the status of the nerves and the vessels for your targets. So I would start with that as the trauma team is resuscitating the patient and really trying to assure hemostasis. It sounds like the child was in some degree of shock. So I would start with damage control resuscitation initially, getting some hemostatic resuscitation going with plasma, and then red cells as needed, get them up to the operating room together with the injured extremity after you've ruled out other associated injuries, and then really start to work on the amputated part on the back table, and then take it from there.
Dr. Boyer, would you take that same approach?
I think that sounds like a very reasonable approach, and at this juncture, I would phone a friend and get my microvascular transplant folks involved.
Dr. Mayr, what would happen in Basel?
I think we would also call the colleagues from the microvascular department, and after preliminary stabilization using key wires, I think the reanastomosis of the vessels would be done under microscope, and I would think this will have a strong vasospasm after the operation. So it has to be cared for at the intensive care unit, also for the thrombosis of this anastomosis, which is critical, I think.
So, Dr. Elster, have you run into this in Afghanistan, Iraq?
No, we haven't in Afghanistan or Iraq. But a couple of comments. If reimplantation is an option, obviously getting access to the artery, infusing cold lactated ringers, getting the limb on ice as early as possible is important from the reimplantation side. The other part of that is that if reimplantation is not an option, preserving limb length in the upper extremity for future hand transplant is critical, and we're actually pushing out that in our clinical practice guidelines, especially with respect to those upper extremity amputations, because the more distal your anastomosis is in the hand transplant world, the better your outcomes are.
Dr. Petty, would you go ahead, please?
Sure. So we did, a full assessment of the patient regarding the other injuries, and he had a grade 1 spleen and some pretty minor pulmonary contusion. So in terms of the life and limb-threatening equation, I think he tipped more towards the limb-threatening situation than the life-threatening situation. So promptly from the trauma bay, he was taken up to the operating room, and it was definitely a team sport. I have to give a lot of credit, really all the credit for this child's outcome regarding his extremity to the orthopedic, microvascular, plastic surgery teams. And as has already been mentioned, 2 teams were in process, one on the back table with the amputated arm and the other on the patient's side, in addition to activity from myself and the anesthesiologist regarding resuscitation and blood products and access and all the other things that go into creating an environment for a limb to possibly survive something like this. So it was a long night for that child in the operating room, but they were able to anastomose the artery and 2 veins, a brachial vein and a cephalic vein, as well as primary repair of 2 of the nerves, the ulnar and the median nerve, and then a nerve graft for the radial nerve, and brought him up to the pediatric ICU. He was just and then did distal fasciotomies in the forearm and in the hand. As you can imagine, he had several postoperative issues. One was in a 2-year-old, the thought of trying to have him be still so that there's no kinking of the venous anastomoses is a tall order. And so our strategy for him was to leave him intubated and even under chemical paralysis for the better part of that first week, so that his arm could maintain a sort of a vascularly intact orientation relative to his chest. He did have a bit of an ischemia root perfusion phenomenon, and we were able to work through that. I think his immobilization, introduces new challenges in terms of skin care and pressure sores and that sort of thing too. But he had several trips back to the operating room for debridements, inspection of his anastomoses, bringing over tissue from the chest to help cover tissue that was lost, and ultimately came to skin grafting to cover what couldn't be covered with tissue primarily from the arm. And these are photos of the child from about a month ago. This is about 9 months after his injury. The good news is he has a viable extremity. The nerve function of that is below the shoulder, nothing yet. The caregivers for him have reported seeing some thumb motion, but the physicians who've been following him most closely haven't seen anything yet. But he's not even a year out, and the thought would be that you don't make final decisions about neurologic outcome until you've given sufficient time for regeneration. But that's sort of where we are with him today.
Well, I think that's really an outstanding experience there. Go ahead there, John, on your outcome.
Oh, just summarizing sort of where we are. That's an X-ray of his arm. They did 2 orthogonal plates there to salvage or to stabilize the bone. They did shorten it, as has already been mentioned, in terms of having additional length for repair of nerves and vascular structures in the upper arm.
Well, congratulations to your team. That's absolutely outstanding. Outstanding. What I'd like to do, do you have a last-minute comment there, John, you want to say about the patient? Would you do it again?
I think so. I think, as we talk about key concepts, I think the emphasis on function is right. There's certainly pretty good survival data for replantation in children, and I think most people that engage in replantation surgery would say that being young is a positive factor, not a negative one. But I think the function that you get from doing something like this has to be compared to not necessarily the uninjured side, but the alternative of an amputation and prosthetic. And I would just sort of invite the comments of the panel, but I think both sides of that equation are moving forward, both in terms of microsurgery, rehab, and sort of limb salvage, limb preservation, but also on the prosthetic side, too. We heard a great presentation on the webinar last year from Dr. Ling about sort of advanced prostheses and cortical control and that sort of thing, too. And since putting this presentation together, I've made contact with him, and it's sort of not there yet for children, but it's encouraging as someone who's been involved in the care of a child like this to think that within his lifetime there may be other things available if his native neurologic function doesn't recover to a point where that arm is very functional. So I think it's a very heroic effort on the part of a lot of committed people to salvage this child's arm, but we haven't heard the end of the story, and I think in some ways that's encouraging because he's not had much in terms of function yet.
Thank you very much, John. That's really fantastic. It's a surgical trial, and I agree with this youngster's care. But maybe we go through the panel real quick because we've got just a couple of seconds. Just give us your last impression or opinion, either about this case or anything else that you've seen over the last hour and a half. Dr. Boyer?
Compartment syndrome, think about it, know how to do it, know your anatomy.
Dr. Elster?
Just beware over-exuberant use of tourniquets. Oftentimes, first responders will put tourniquets on anything and everything, assess them quickly, and determine if you need them.
Dr. Schmitz?
I'm sorry, I was typing. Say it again.
What's your last thought here? You want to leave with the audience?
I just think the concept of damage control orthopedics and stabilizing these patients is very relevant, something that we've learned from the war and can be applied to pediatric patients.
Dr. Cannon?
Yeah, vascular injury occurs in pediatric patients. We talk mostly about unintentional trauma and vascular injuries, but iatrogenic trauma occurs as well. And my feeling is that with an aggressive interventional approach, you can have excellent outcomes.
Dr. Mayr?
I congratulate Dr. Petty on this tremendous effort to save the arm of this child. Congratulations.
Dr. Henkin?
I would say I would leave a couple of things. Number one, remember that infection is what you want to avoid, and so don't be afraid to take some of these kids back multiple times to the operating room if you can't get it done in one time, and then save as much length as you can because length equals function in these kids as they get older.
Dr. Petty, you got the last say.
Well, my comment would be that cases like this are really a team sport, and I think it's good to have people that are dedicated to the limb, but also those that are attending to the more global things, because there are certainly situations where you might need to sacrifice the limb for the sake of having a healthier patient to survive something more life-threatening.
Well, thank you very much, each and every one of you. That was a fantastic presentation, and we're appreciative of all the efforts that you guys have made on the part of all these kids. So thank you so much.
Are we out of time, or so we have no time for questions?
Well, yeah, you have a question?
We have a
whole list of them?
1,000. Yeah.
Well, how about,
that's what I was trying to say. Yeah,
well, how about pick one or two really?
Well, let me
good
actually ask Eric. You were involved in a lot of these comments and questions from Dr. Maddox. Do you want to address some of those?
How about just one?
I think I did address.
You addressed the tourniquet. Do you want to? Is there anything else to discuss that you want to? That anyone wants to discuss, or should we just leave it at that?
No. What about the
snake bites?
I asked Mark about the snake. What fasciotomy in snake bites? I think Mark and Jeremy.
Do a poll. Do a poll of how many people have had patients with snake bites needing fasciotomy.
Okay.
That's the way.
Has anyone, Mark? The question would be: has anyone had to do a fasciotomy for a snake bite?
Yes, fasciotomy. No fasciotomy.
How about
No.
Okay. Because probably most of the people are going to, because they've never seen a snake bite. So the question is,
third answer, never
That's
seen
down in
one.
Texas.
Right.
They got rattlesnakes in Texas.
Those of you who've seen patients with snake bites, have you ever had to do a fasciotomy? All right, good. While we're waiting for that, I guess we can move on. But
well, what I appreciate you gentlemen would get on the chat and answer these questions that are there. It might take you another 15, 20 minutes, but please do that. I think it would be very worthwhile. We're going to go on to the next section. The next section is what we've done. We've talked about disasters. We've talked about burns. We've looked at injuries on the extremity. Now we're going to talk about the patient who needs to be put to sleep, has a laparotomy, has a problem in the retroperitoneal space, and then some concepts of nursing care. And so I would like to introduce the first